Dear colleague, welcome to this PCR webinar entitled How Should I Treat Patient with Refractory Angina Using the Reducer Device? My name is Thomas Cuisset. I'm working in Marseille, France, and I'm very happy to do this webinar today with Martin Gillard from Brest, France, and Stéphane Verheij from Antwerp, Belgium. So the learning objective we'll try to achieve together today during the next 60 minutes will be first to identify the incidence and the impact, especially on the quality of life of refractory angina, to select the appropriate drugs and intervention for patients with refractory angina, and then to share tips and tricks for reducer implantation. So again, the team for this webinar, of course, will be the three of us with Martin and Stéphane. But a very important and probably the most important actor of the team will be you connected tonight. And would like to keep this webinar as interactive as possible. So really use the chat to send us your comment and question that we will address together with Martin and Stéphane. So for the agenda of this webinar, after this very short introduction, first, Martin will tell us a few words about the concept of the coronary sinus reduction and what are the key evidence underlying the use of this device in daily clinical practice. Then after, we will go directly into a clinical practice with one case that we will present, and we will show a recorded case which has been recorded in our hospital in Marseille. And following this case, we will discuss with Stéphane what could be the technical challenges for reducer implantation and what could be the perspective for the use of this device in our daily clinical practice for the upcoming years. So without further introduction, I would like to let Martin start with the concept and the key evidence. Martin, please.
Okay, so thank you, Thomas, and it will be a real pleasure to present you the concept of this coronary sinus. Okay, so for the next, it will be my conflict. So as you know, despite an improvement of the treatment for chronic coronary angina, there is still some patient who remain symptomatic, and it is around 10 to 30% according to some trials. So it's very an important issue for this patient. So a long time ago, as you can see, in 1950 and 1960, there is a surgeon who discovered that when he make a narrowing of the coronary sinus next, you can see that he improve significantly the symptom of the patient, and also he reduce the mortality. However, in 1967, there is a Favoralo that invents or discovers coronary bypass surgery. So the invention of Claude will be abandoned. But however, now we need to have a treatment for patients who have a refractory angina despite all our treatments. So how does it work? So when you are when you have nothing at rest, the blood in the subendocardial is more important than in the subepicardial layers. When you perform an exercise, the resistance of the subendocardial decrease, and by this way, all the blood go to the subendocardial. However, when you have a coronary artery disease, it is the opposite, and the flow could not go so easily in the subendocardial layer, so you have some pain. So when you perform a coronary sinus narrowing, you have a slight dilatation of the diameter of the arteriole, and by this way, next one, you can inverse the resistance, and by this way, you can improve the vascularization of the subendocardial layers. So it's very, very important. How do we do that? It is a stainless steel balloon expandable, as you can see. It's a normal stent, only single size, and you have to implant. You have to make a sizing of the stent when you implant in the coronary sinus, and then next one, the central part, as you can see, is narrowing, but there is no injury at all of the sinus. Next one. And if you need, for example, to make a CRT, you can avoid, you can delete this narrowing with a new balloon, and you inflate the balloon, and the narrowing of this stent disappear. So how can we do that? What is the data for that? So Stéphane, who are with us, perform a very important trial, which is a double-blinded, randomized, sham control, because, and I think Stéphane will explain us in more details later. So, and you can see in this trial with a sham control, you can see that there is an improvement, a dramatic improvement of the symptom of the patient. Next one. And also, they change, as you can see, between the treatment and the control patient. So we perform a registry, a large one, with a 3-arm, and one of this arm is a follow-up of the patient who are included in the sham control, in the first Coursera trial. And we can see that by this way, next one, we have the reduction, a very significant reduction of the symptom, in improvement of the symptom, but this is go on 5 years, so there is no modification. This improvement persists and it stay around 5 years, so it's very, very important. And what about the complication of this data? You can see that there is only one complication, which is an acute MI due to the sinus reducer, but no major stroke, no cardiac death. So it's very important. And also this is important because these patients who have a refractory angina have a lot of hospitalization before the treatment, as you see in the second next. And you can see that they decrease from 78 visits to 22. So this reduction also is a very important reduction. We show that there is an important improvement of the life of the patient. Next one. So my take-home message will be that this refractory angina, it's a common disease and it's very important for patients. Next one. So the sinus reducer realize a focal narrowing, and by this way increase pressure in the coronary sinus, and by this way also decrease the symptom of this refractory angina patient. Next one. So in this sham control performed by Stéphane Verhey, so this reducer was associated with a significant improvement in symptom and quality of life, which is very important in this patient. Thank you so much.
Thank you, Martine. I think it's very clear, and it's we like to see the cath lab and what we are doing in the cath lab, but I think it's always good to start with the underlying evidence to support what we are doing. Maybe, Stéphane, just a simple question on the sham control design. We know that's something which is quite rare in interventional cardiology. We had that recently in Orbita. We had that for renal denervation. So could you just explain in few words how it works for the people joining us today?
Sure. First of all, thank you, Thomas. It's a pleasure to be with you today, and thank you, Martine. And I also would like to thank Neovasc for supporting this event here. Now, indeed, the sham control is something very unusual. There's been many trials, but not a lot of trials with devices where we have sham control trials. And what does that mean? That means that the patient is unaware of the treatment arm that he or she is going to get into. So patient, when you do the consenting, it's a novel technology that you want to introduce to the patient. And you have to try to convince them but you have to tell them there's a 50% chance that you will get the device, and there's a 50% chance that you will not get it. And after we have done the treatment or the sham, you will still remain blinded until the data will be unlocked, depending on the primary endpoint. And in this case, it was 6 months. So basically, the patients need to be followed for 6 months or a year, whatever what the endpoint comes first, and they do not know what the treatment is. That means that the operator should not be following the patients afterwards. They have to remind, those are the ones, the operator is actually the unblinded person, but the patient needs to be seen by blinded physicians, blinded nurses. And only then, after 1 year for all patients, they can be unblinded. So that's a sham control. And there's very, very few trials in device that have had a positive effect. And the reducer was actually one of the first ones who was able to demonstrate that. Nowadays, we are doing more trials, sham control with devices.
Yeah, thank you, Stefan. So it means that when we assess, let's say, subjective symptom or quality of life, I think it really, really makes sense, and it makes the evidence much more robust. Martin, maybe before going to the case and really to see how it works, I'm sure that's what people would like to see tonight. A difficult question. We know that we are in a community where the innovation is coming and people are going very fast. So could you tell me why we had 7 years between the New England Journal, major study, big evidence, shame control, and the big increase of reducer implantation in Europe and in France, for example?
Oh, I think it's a very important question. And in France, it's normal because it takes time. Despite the restriction of our legal authority, it takes time for everything. So it takes 7 years for France in order to be able to implant a sinus reducer with a reimbursement. It's a temporary for the moment, but it exists. But perhaps also it is because it's for patients who have a refractory angina. So this kind of patient, in a lot of institutions, they said, okay, there is not a lot of patients like that. So I don't, I don't care, but the vast majority of our patients, after our PCI treatment, surgical revascularization, we improve it. So we said, okay, this guy, okay. But perhaps it takes time for our community to say, okay, now we have to treat this patient who have a refractory angina. Yeah. So perhaps
you mean the feeling that the target was not big enough, and also maybe the interventional cardiologists think that they can solve everything by doing complex PCI, CTOs, opening everything. So maybe refractory angina, it's like a failure for interventional cardiologists. So maybe it was a kind of, what is your view on that, Stefan? Because I know that you implant the device for many, many years.
Yeah, well, I think we started implanting the device back in 2009 or 2010. So that's about 12 years ago. And you know, at first when you talk to people, people just don't believe it. Why would this thing help? You know, we're used to putting stents in arteries to avoid blockages, and now you're going to create a blockage in a vein. It's just the opposite. So I think until some years, people didn't really understand the mechanism as to why the reducer was working. And of course, it's a very difficult area. Like you said, interventionists try to solve that. And there were very little convincing data with other technologies. There was stimulation of the nerves. There was blockades of the ganglia. There was counterpulsation. And all these didn't work. And so therefore, I think it took a long time. But now that we have data based on a randomized trial and lots of registry data, and the fact that in all these trials, across very different continents, we see the same set of data coming back, 70%, 30% increase. So I think people start to realize this actually works. and we also have the mechanism. We understand why this works. So I think that's and like Martine said, it takes it takes a little bit of time, and
Yes.
also it's an area where we as interventionalists are not very familiar with. You know, the
Yeah,
coronary sinus.
it's more or less the room for the EP guy. Usually, we'll
Exactly.
discuss that. So it means that when innovation is too innovative, sometimes it can take more time. So I think it's good that we really set the stage and reviewing the key evidence supporting the use of the device for patients with refractory angina. So maybe the what is coming next is really to share with you a case where we use. So maybe we can come back to this to the slide and just share with you really let's say a typical candidate for the use of coronary sinus reduction. Can we go back to the slide, please? Yeah, thank you. So that's a case which was admitted in our institution in Marseille, and for which, as you will see, we recorded the case in our cath lab. So it's really let's say a usual candidate. It's quite young patient. Is 57. Sorry. He has the usual risk factors. He's diabetic patient. He stopped smoking for a few years, and he had prior revascularization. And that's really the case in most of the candidate we have, meaning he had CABG already, he had PCI, but in spite of that, he came back to our institution for refractory angina with the clear evidence of ischemia on the non-invasive testing. He has a good LV function, and he has as anti-ischemic drugs only, let's say, not low dose, but not optimal dose of bisoprolol. So he was admitted for invasive coronary angiography. So as you can see on this steel frame, he had a really complex coronary artery disease on the native vessel. And you can see we have a kind of aneurysm of the left main with occluded LAD and really diffuse disease on the circ and the obtuse marginal branch. The right was occluded, and this patient had just a Lima to LAD, which was patent, but as you can see, the distal part was also really diseased with some diffuse and significant disease. And as you can see here, we had also collateral from the Lima LAD to the LCA. So we really had a patient that we consider as no real option for revascularization. I'm sure that many interventional cardiologists will say you can try to open that and that. That's fine with that, but we really consider that for this patient, if we want to stay reasonable, the first decision was to start by optimization of the anti-ischemic drugs. That was the first attempt. So we optimized beta blocker up to 10 milligrams. We gave the patient long-acting nitrates, nicorandil as well. But then we saw the patient again 6 weeks later, and there was no clear significant improvement. There was some improvement, but the patient still really had refractory angina. So decision was to go for this patient for coronary sinus reduction. And before going to the cath lab, I would like to hear Stefan and Martine, I think, on this specific question. So we spoke about the evidence, and the next question is really, what is your typical candidate for coronary sinus reduction, Martine, today in breast in your practice?
Is exactly the same as that. It was patients who have a very diffuse disease, impossible to make another other thing, no CTO, possible, no vascularization, surgical vascularization. So in this kind of patient, we try to implant a sinus reducer. I forgot to tell you that if the disease is only on the right coronary artery disease, it's not working, because you can treat only patients who have a left coronary artery disease and not the right, because the right doesn't go through the sinus. So this is important. But in your case, you have a diffuse circumflex and obtuse marginal disease. So perfect for me.
Yeah, Stefan?
Yes, I would like to. I mean, this is a perfect example. The data supports basically the treatment of this patient. Supports the use of this device in this particular patient. It's a no option patient. I think CTO is not a good option. He's on full medical treatment, optimized. He has signs of ischemia on objective testing. And so basically to me, that's a perfect candidate. And that's basically also what we have done in all the trials, in the randomized trial and also in the registries. Now, I echo what Martine is saying regarding in all trials, we actually looked at the ischemia had to come from the left side. But as you know, there's always people who want to push the envelope and who want to test and see whether this also works in right coronary arteries or ischemia from the right side. And there has been some preliminary evidence, just for the sake of completeness, where there have been positive reporting of the use of the reducer in territories coming from the right. So is that now saying that we should treat all patients? I'm not saying this, but it's definitely an option to look into.
Yeah. Maybe, Martin, also an important question is, for PCI, when we have patients with angina, in the guidelines, we should try drugs first and then to do PCI, but we never do that. If we have a critical stenosis of the right, we'll fix it first attempt. So will you do the same, meaning patient with refractory angina, you always try to optimize the drug treatment first, and then the second step is to put the reducer device, or you go upfront with the reducer device?
No, I think for this case, I always want to go quick, but for this type of patient, I prefer first to optimize the treatment. I know that for interventional cardiologists, it takes too long time. But in this particular patient who have a refractory angina, we try to do something with the revascularization. It's not possible. So for this kind of patient, optimal treatment is important. And also, as Stefan said, to look for the ischemia. If there is a documented ischemia, I think also it's important.
So you mean the good patient is refractory angina in spite of optimal medical treatment? That could be the, let's say, for the people listening today, the good candidate. Maybe last question for you, Stefan, before going to the cath lab and see really practically how do we do it. We know we are living in a CTO world, and we are doing 1, 2, 3 attempts of CTO. Would you consider this device as an option in patient with angina and really, really, really complex CTO with, for example, 1 or 2 failure before coming to your institution?
It depends. It depends on who you're asking, of course, Thomas.
To you, I'm asking to you, Stefan.
Absolutely. But I think the evidence is there. CTO, in all honesty, and with all respect to the CTO operators, it has not proven that much of a benefit for the patient. Whereas putting a reducer in those territories where you have no option for treatment, either by PCI or CABG, and they are under medical treatment, I think the reducer is a very valid alternative and good option.
Yeah, so it's 2 different options, and it's probably also depend on the complexity of the CTO and the profile of the patient. So it's just a new tool for this complex patient.
In addition to that, as Martine already alluded to, it's a very safe procedure, whereas a CTO, I think, has it's much more inherent for complications rather than the reducer. But of course, that's in a personal opinion, and you can only, the people who have the experience can only speak for that.
Oh, but it's interesting, I think, to be open-minded and just to think and to change probably sometimes a little bit the rules and the things that we are doing in everyday practice. So I think now it's good to go to the cath lab, to the recorded case that we did in Marseille. And really, again, please feel free to send us your question and comment, and we will address that with Stefan and Martin just after the case.
Hello everybody, welcome to La Timone Hospital in Marseille. My name is Thomas Cuisset and I'm very happy to work today with my partner Pierre de Haro. And we will treat with the reducer device the patient you've just seen, which is a typical patient with a refractory angina. So as we discussed, the procedure will start with the echo-guided puncture of the jugular vein. So we check on the angio that we are on a good spot. So next step is to put the 9 French sheet in the jugular vein. Yeah, so Pierre, indeed, the setup of the room is very important. And just after the puncture, there is 2 things to do. The first is to go LAO 30, which is the projection for the implantation of the device, and also to have the table like this, as we will work for a subclavian TAVI, for example. We start with multipurpose catheter and the G wire. So we see we are in the right atrium, and we try to go into the coronary sinus, which usually goes up.
Okay.
And what we will do first, we will do an injection just to assess the anatomy of the coronary sinus, and also to look at the size, to be sure that the size of the coronary sinus is between 5 and 15, which are the good dimension for proper device implantation. So I have no backflow here, so I'm probably against the wall. So just to be sure, we start with just the angio of the coronary sinus.
Okay.
And so the next step, we will ask Sebastian, our technician, just to do kind of QCA as we do for coronaries, and to be sure that the dimension are between 5 and 15. So Pierre, following the angio and the measurement made, we can see that we are between 6 and 8, which are a good dimension for the reducer device implantation. So at this stage, it's let's say the validation based on the anatomy. So 2 things to do is to open, let's say, the kit, because we know we will proceed with the procedure, and also to give some heparin at the, let's say, PCI dosage, which is 70 units per kilogram.
Perfect.
So next step will be again to put the G wire in the coronary sinus here. For the next step, when we know that we will proceed with the reducer implantation, just the setup of the room is really important. Again, it's LAO 30 and the table is like this, and we have the screen in front of us. We have the feeling that the anatomy is quite difficult, so probably we will take a wire with more support. So Pierre, we've seen that the anatomy is somehow challenging. We try first with the G35 wire, but we didn't have enough support, so we decided to try a Terumo stiff. And again, it was not enough, so we decided to go for super stiff with a 1 centimeter tip. And we can see that now we have a good distal position. And my advice will be always to have a kind of reference on the other screen and to exactly try to define the landing zone during the implantation. So Pierre, we say that the anatomy of coronary sinus is fine for the device implantation. We had to struggle a little bit to put let's say, the good wire according to the patient anatomy. So next step is to open the kit of the reducer, which come with first 9 French guiding and 9 French valve connector here. And on the other hand, we have the reducer device that we should just remove from the first plastic tube. Then you just remove the metallic still, and then there is still a small plastic tube for protection that you have to pull and push, but very gently to be sure not to mobilize the reducer device, which is just here. Okay. And the next important technical step is when we will do the inflation of the reducer device, we have to put very small proportion of contrast, because we know that the profile of the balloon sometimes it's quite challenging to be fully deflated. So we have usually for PCI, we do 1/3, 2/3, but in this case, it's really 15-20% of contrast only. The next step will be just to a little bit pre-shape the 9 French sheet. And what we will do, what we used to do also for coronaries, is just to do mother inside by as you can see that Pierre will put the initial multipurpose 5 French into the 9 French, and it will make, let's say, the profile of the whole system a little bit easier to navigate in the right atrium and in the coronary sinus. Good. Also, Pierre, I think important point is also to keep always the same projection, because we can see that now we have the reference. So we can say that the distal part of the landing zone should be just at the right part of the spine.
Yeah.
And in this case, we know exactly where we are. Of course, we will be able to inject contrast also in the guiding, but it's a good starting point to have that in mind.
So you don't want to be too close to the ostium, and you want to be just before the bifurcation. That's
Yes, exactly, Pierre. So we will just, let's say, put the distal tip of the guiding just a little bit distal to the pre-specified landing zone that we decide during the first injection. So we go with the mother and child system. And we have to go very gently in the right atrium, and to avoid what we call a belly sign, which is that the curve in the array is becoming too large, because we know that it's not appropriate for device navigation. So Pierre will really have to manage the wire to be sure that we don't have too much belly sign.
pushing slightly the wire to help, but it's challenging.
But we go, as you see, exactly as we discussed, Pierre, we go very gently, and we try to avoid to have too much belly sign on the lateral part of the right atrium. We go very gently. Okay. The patient is fine, is obviously very stable. So first we go to the landing zone, as you can see, with the multi-purpose, which is, I think now we are in a good position. So next I will do fixed point on the multi-purpose, and we will very gently advance the 9 French guiding. So again, we can see that we have a belly sign, which is a little bit too much at this stage. Yeah, we have a nice jump, Pierre, because we really seen that the guiding enter the coronary sinus. So now it will be easier exactly to reach the position that we define. I think now it's a good position, if you agree, Pierre.
Perfect.
And we can just remove the multi-purpose and keep the wire in place. Yes. And the next will be to put the reducer on the wire. We are in place now with the guiding and the G super stiff wire. So the next step will be to proceed with the reducer implantation, which is going on the O35 wire. So importantly, we have to nicely open the valve when we go with the device to, again, it's to avoid any damage or embolization. And we'll go very gently with the navigation. So again and again, so we can see you have
three markers.
Yeah, we have 3 markers. And so the idea will put the distal one just at the tip of the guiding without going outside the guiding. So we go gently, and again, we try to avoid to have the famous belly sign with the huge curve in the lateral part of the right atrium. And I go really, really gently up to the tip of the guiding without going outside. And what we can do, Pierre, just to check that the device is nicely in place between the marker 2 and 3. Mm-hmm. And what we're gonna do next is just to have fixed point on the register and just to remove the guiding between the first and the second marker, just to free the space for the reducer device to be able to be deployed. So as we say, Pierre, here, what I will do is to have a fixed point on the reducer device, which is going always a little bit forward, and just to remove the guiding between the marker 1 and 2, and then the reducer is free in this case.
Yeah, the feeling is that despite the challenging anatomy, it's everything is going smoothly and it's very stable.
Yeah, I think the profile of the device is good as long as probably we select the good wire to have enough support for the navigation in the right atrium and also in the coronary sinus. So Pierre, what we did now is just you just put 1 bar inflation just to stabilize the device. But if you look at the landmark that we had, I think we are probably a little bit too distal and probably beyond the bifurcation. So I think we can come back very gently. I think here it's good. And what we can do, we have the lateral port here, and we can do a contrast injection to see exactly where we are. So be very.
You can aspirate.
Yeah, we have to aspirate. We have good backflow. Of course, we are in the venous system, but we have to be sure that we have no air embolism. So I think we are in the proper position. I think, Pierre, exactly where we want to be. It's distal enough from the ostium. Of course, so Pierre, we can say that we are in a good position. So what we can do next is to go up to 3 atmosphere. And the idea is to keep the device inflated for 30 seconds.
Okay, we are at 3 atmosphere now.
So that's good. We will just make a graphy to see a little bit the shape of the device. Huh? And I think it's fine. And what we will do during the inflation, we will just give a little bit more contrast that to be sure that the device is well impacted in the wall and there is no risk of embolization. I think it's good. It's good example here, huh, Pierre. And what we can see that we have the feeling that the device is already a little bit bigger than the coronary sinus, which is a good way to lower the risk of embolization.
Or do you want to deflate the inflator, Thomas? Do you want to go by unscrewing it, or should I go negative first?
That's a very good point, Pierre, because we know that let's say that the profile of the balloon is not ideal, and we might have some interaction between the balloon and the device. So the rule is really to try to empty completely the deflator, meaning you deflate everything, and when it's fully empty, we will put it many times at negative pressure to be sure that the profile of the balloon is really ideal. So as we say, Pierre, we will start by empty completely the deflator here. And when it's done, of course, you have more space to have optimal negative pressure.
It's still coming back a little bit.
But it's fine. I think it's just what we had. And we will do it, as we said, many times, and really to wait, because I think the risk, as we experience for coronaries, if you try to remove the balloon too early, we might have some mobilization of the device. Okay, so Pierre, now the balloon is fully deflated, so we really take time. We'll just do a short contrast injection. And it's fine. We see that the device is nicely opposed to the wall with most probably very, very low risk of embolization. Now the next step is to remove the balloon, and as we say, the profile is not ideal, so we put that negative many times. But also a nice tips is just to go with the guiding up to the middle.
Inside, if you can.
Inside, if you can. It's true that in this case, it's a little bit challenging. So the idea is really to try to go a little bit deeper with the guiding, to have more strength to pull on the balloon and reduce the risk of embolization, and of course always keeping the wire in place.
So it's the most important. Keep the wire distal.
So as we discussed, Pierre, we are really now in the middle part of the device, and next step, you will keep the wire, and I will gently pull on the balloon and also on the guiding, because we don't want the guiding to cross the central part of the device. So I will go, as you can see, very, very gently.
Okay.
And now the balloon is back in the guiding, and we have still the wire in place. And the next step will be just to do a last injection, just to assess that everything is fine, and then the procedure will be done successfully. So next step here now is just to advance the multipurpose to have, let's say, a distal injection. And again, it's important to keep the wire in place.
So you're recrossing it.
Yeah.
It seems to be slightly more difficult, a bit of interaction, but it's going.
Yeah, it's going. I think
pressure.
Now we are distal to the, so it's fine now.
Okay.
Good. And we will do distal injection with two information, of course, the position of the device, and we will assess that last time, but also that the procedure was safe, because as we've seen, we had to use stiffer wire and not only the regular G wire. So we want to be sure that we don't have a distal perforation. It's good. So we inject. So I think position of the device, Pierre, is good, and it's just really just proximal to the bifurcation, and we don't have a distal perforation. So I think it's a good result in this case.
Yeah. And now, Thomas, we just completed the case. What is next for the patient? Is going to go home today or tomorrow? Do you need an echo, and which treatment do you need for your patient?
Usually it can be ambulatory patient. And this patient arrived yesterday because we wanted to discuss a bit and to explain, but usually the patient will be discharged just this afternoon. The follow-up will be planned between 6 and 8 weeks, and we will probably repeat both the clinical assessment, but also maybe the non-invasive testing. And in terms of antithrombotic strategy, current recommendation is to give DAPT for 3 months after the reducer implantation. But most of these patients with very complex coronary artery disease, they already have aspirin and clopidogrel on board, so there is no additional antithrombotic strategy.
Yeah, so Martin, Stéphane, so we've seen, I think, a nice example. We discussed about the case selection, but also the procedure itself. It looks small. It's true, it's really a step-by-step procedure, and we have to respect the different one. Stéphane, I had an interesting question from one of my fellow yesterday. He asked me, is it a simple procedure for interventional cardiologists? So it's as simple as that. This question.
Well, first of all, Thomas, I have to congratulate you for a very nice and educational performance here. And the way you did it looks like you know the answer yourself. You know, it looks very simple, even though there may have been some difficulties in getting the guiding into the coronary sinus. But as such, basically, the procedure is a simple procedure. Yet there are some tips and tricks that one needs to know before he goes into that coronary sinus. We as interventional cardiologists we cannot say we are EP doctors, so we're not very familiar with the anatomy of the coronary sinus. We're not used to perform the procedures in the coronary sinus. But all in all, once you know how to deal with these tips and tricks, I think it's a very steep learning curve. Once you've done 2 or 3 cases, you should be able to do it by yourself. So the answer to you is yes, it's a simple procedure, but there are some little things that we need to know.
Yeah, thank you, Stéphane. Martin, would you like to, again, for the people who are just beginning maybe their activity with the coronary sinus device, what will be your recommendation or tips and tricks, the main take-home you will propose?
So first, as Stéphane, congratulations for this very exemplary case. So I think the first tip and tricks is to respect all the steps. It seems easy, but we need to respect the step. The second one is to make the puncture with under echo. I think it's important. We don't use to puncture the jugular vein so often, so it's better to do that by echo. To have a good support, I think it's very, very important because we have, as you saw in the case, a large curve in order to go to the sinus. And sometimes it's difficult to go to the sinus to make the insertion of the guiding catheter inside. But for me, the most important is to have a very good deflation of the balloon. Because as you see, there is sometimes you can make an embolization of the reducer if your balloon is not so well deflated, and when you take it out, you can the device can move and go inside the right atrium. So it's not good. So if you respect everything and you have some very important tip and tricks, I think it will be good. It will be easy.
And thank you, Martin. And maybe, Stefan, we have a question from Giuseppe. We've seen that in this case, let's say we start with the multipurpose and G-wire, and when it's easy, okay, it's let's say the standard of care. But when it's more challenging, I know that you have plan B, C, and Giuseppe is asking whether we can do some kind of balloon-assisted tracking to try to place the guiding catheter in the good position in the coronary sinus. Did you already use these tips, or what are the other options?
Well, it's a good question, but so far I have not been in a situation where I had to do it myself. If you do it like very stepwise, and you have your guiding or your guide wire in there, and the guiding, and it doesn't work, one of the key issues here is to take time and be patient. Don't be in a rush. It's not like a PCI for coronary arteries where you have to do it quickly. And if you take your time and do it slowly, and you advance your guiding slowly into the coronary sinus, sometimes, even though it sounds weird or strange, but sometimes it jumps into the coronary sinus by itself. So I think, take your time. Don't go too sophisticated with all different techniques. There's basically no need to. You need to have good support, and you need to be patient.
Yeah, thank you, Stefan. Martin, did you already use this let's say bailout technique in very challenging anatomies?
Yes, but I think it's this important what Stefan said. Be careful and be slow. It's not a rush. It don't take a lot of times, but you have to be very, very careful.
Yeah, I fully agree. And also we have to keep in mind that we want to improve patient quality of life, to improve the symptom of the patient. So I think we really need to end up with a very safe procedure as always, of course, but probably even a little bit more when we do a procedure for quality of life and symptom, I think, to my view.
Exactly.
So I think it's nice
Exactly.
that we've seen the evidence with Martin, then we've seen what could be today in our practice the good candidate for refractory angina and for the use of the device. We've seen the procedure itself. So I think now I would like to hear you, Stefan, on the, let's say, the challenges, and the challenging anatomies is one of among those, but also what could be the perspective for the use of this device in our daily clinical practice for the coming years. Stefan, please.
All right. Well, thank you, Thomas. I'll try to cover. It's not, we only have 5 to 7 minutes to cover this, so it's quite challenging. But the more I talk, the less time I have, of course. So we'll go to the next one. Those are my conflicts. So basically, first of all, we're not familiar with it. We need to find the coronary sinus. How do we find it? First of all, we try to use with a multipurpose. We give ourselves 3 to 4 minutes to find the coronary sinus using the multipurpose. Inject some dye. Have your 035J wire and ready if need to be. Sometimes it just goes in straight. Sometimes you have to look for it, the coronary sinus. And if I don't find it immediately in 3 to 4 minutes, I switch quite often to a Amplatz left 1, which is somewhat unusual, you may think, but it's actually a very good catheter to engage the ostium. Now, don't try to bring the Amplatz into the coronary sinus because that's not going to work. You take your wire and you feed it into the coronary sinus all the way to the end. You will take out the Amplatz and then you will exchange for the multipurpose. And the multipurpose, you can easily slide it into the coronary sinus all the way down to it, remove your wire and make a firm, nice injection. That allows you to have a good idea of the sizing, one, and second, where am I going to put my reducer? So the landmarks here are important. You want to be as close to the ostium of the coronary sinus, but you don't want to be too close because then the size becomes too large and you cannot properly implant the device. So that's important. Don't try to get into the coronary sinus without using the wire. I've seen people using the multipurpose and slide it into the coronary sinus, and you may actually go subintimal and cause a huge dissection. So that's an important message to take. So the positioning of the guiding catheter is important. There are some challenges, and the challenges are, as you can see on this slide here, is first of all the angulation of the coronary sinus. You can have a very shallow angulation. You can have a very steep angulation. If it's shallow, then it's going to be easier to get your guiding into the coronary sinus. If it's going to be steep, then you may run into problems. And then, therefore, support is going to be the key. The other one is the presence of bends. As you know, hearts may be twisted, especially hearts that have undergone bypass surgery. Sometimes there's little rotation. That makes it more difficult. And also, therefore, you may have to be careful and take your time. And then lastly, also the presence of valves is also another issue. And therefore, there are some tips and tricks as well. As I already mentioned, how are we going to solve all this? Well, the first thing that you have to take with you when you do the case is be patient. Don't be in a rush. This time, like Thomas already mentioned, it's a very important point. Basically, you're here to make the patient better and not to cause any complications just by trying to push the envelope as much as you can. So that's not good. And you will see, and this was a very good example by Thomas during his educational case, is take your time and be slow. And you sometimes have to twist and torque your guiding as you go into the coronary sinus. Now, you can do that once you have your wiring there. How are you going to get your guiding? The guiding is a little bit stiffer. You have to bend it, as you could see from the presentation, from the case. But sometimes it doesn't work with the reducer straight into the guiding, and you may have to use a mother and child technique. And the mother and child technique, like Thomas has done during his case, is very helpful because it gives you more support. But again, don't try to push it directly into the coronary sinus. Take your time, twist and torque. Eventually, you will get there. And if not, then you will have to go to a grandmother and child and a grandchild techniques where you have another supportive catheter, or you can take, if no way to get into the coronary sinus, you can always ask your EP colleague who is next door, can you come and help us with a decapolar catheter? We can try to handle it, but we are not that experienced by twisting that device. We're not used to it. And within minutes, they can be able to get into the coronary sinus using the decapolar or the EP catheter through the guiding that you actually will be able to use. Remember, it's a 9 French, so it's something that you need this size to get your device into the coronary sinus. In terms of wires, the most straightforward wire is the 035 wire, long wire, that usually does the job, but depending on the bends, you may need more support like an Amplatz super stiff wire, or if it's some valves, you may use a Terumo or even a coronary wire, a 14-inch wire to get into the coronary sinus. But then you have to do it all stepwise. Once again, I like to remember you that you have to do Slowly, take your time. Don't be in a rush. You don't want to harm the patient. And so basically, those are the, we can go on here for a long time about tips and tricks, but I think those are the most important messages for you if you have to start doing these procedure. And remember, also Martine has already covered this. It's a safe procedure. Not going to go in detail here. This is data up to 18th of February 2022, where you basically see that there's 2 patients out of the 319 patients that have been treated. So very, very positive and encouraging data in terms of safety. Now, there's 2 things that I want to cover. Dissection of the coronary sinus, I mentioned that. If you have a dissection by your guiding or your catheter, just leave it. Don't do anything else. Bring the patient back in 3 months. It's going to be healed. Unless, of course, you have an infusion where you have to do a pericardial drain. That's a difference. One of the 2 more important things here that can happen is migration and embolization. What do I mean with that? Migration, you've seen it's a rather bulky device, and it's not like a stent mounted on a balloon. It's a little bit bigger, and therefore it's not that much covered or difficult or safe to have it on the balloon. So be careful, and so never exit it from the guiding unless you want to implant it and retract the guiding. So that's important. Proper sizing is important. And again, as I mentioned, you don't want to go too proximal because the sinus may be too large, and you don't want to go too distal because the sinus will be too small. So it's somewhere in the middle or the proximal third, depending on the location and the sizing. And you have to do proper sizing, like it was demonstrated already in the case, and like Martine was saying in her introduction. You have to overexpand it by 10 to 20%. So use sufficient inflation procedure. Don't go too high, but high enough. You need to have a step up and a step down. And again, also what Martine has alluded to, a proper deflation upon withdrawal of the balloon. Remember, the middle is the neck, and the neck is not expanded. So you have to, as you pull back your balloon, you have to bring the fluid that is in the distal part back through the neck. And you want to make sure that there's almost no fluid left into that distal part so that you are easy and good to go to withdraw it. So those are important little things, but very critical things to help yourself and help the patient. In case you have a migration or an embolization, a migration means that it's not properly sized, it's not against the wall. So what are you going to do with it? You cannot really inflate it. It's not sitting against the wall. In that case, what you can do, as long as it's still in the coronary sinus, take a peripheral balloon, somewhere between 5 to 8 millimeters, depending on the size of your coronary sinus, and inflate it against the wall. Once you've done that, take another reducer, and you can do the same procedure and implant it at the site where you have expanded your stent. It's going to be safe. I've done it once, and it was a good outcome. If you're not able to retrieve it, then of course there's the option of snaring. And I know of cases where it was impossible to snare, where the device, and this is just a bailout situation, where the device got lost, went into the RV, into the pulmonary artery. So the question becomes then, what are we going to do with it? Are we going to leave it? Are we going to just take it out? And I think the best here is to just leave it, because it's a small device sitting in the pulmonary artery. It's an open mesh. It's not going to get any occlusion or any pulmonary embolism. It's going to be, there's been some cases and patients are all doing fine. So in that case, I would just leave it alone. If you want to snare it, make sure you have to come from femoral and you have to take a large bore just to make sure that you can take the whole device out. And then lastly, in terms of perspectives here, there's been a number of trials done, a number of registries. There's a lot going on now. The first that you see is obstructive coronary artery disease. There's a study in France. There is a study in the UK ongoing. There's a large COSIRA 2 ongoing, which is a continuation of the COSIRA 1, basically what we've done in Europe and Canada. That's enrolling over 300 patients in the US. And then, of course, there's a lot of interest in the INOCA-ANOCA. And also there's at least 4 to 5 trials ongoing for patients who have ischemia, but no obstructive coronary artery disease or patients with angina and no obstructive coronary disease. And I have to conclude here because time is just over.
Yeah, thank you, Stefan. I think it was it was really clear to see really practically how to overcome the challenges, how to deal with the very few, as Martin say, very few complications, and finally, what will be the perspective according to the evidence which will come next in the coming years. Maybe just before a short conclusion, just one question that we had from Amir for you, Martin. It's how long does it take for the endothelialization of the device?
I am not so sure that we have the answer, but we decided to keep the treatments adapt during 3 months without any evidence of that. So we know that the improvement of the patient, it will be at 1 month. After 1 month, it takes time, but the time to make the endothelialization, I don't know exactly.
Okay. Yeah, it's difficult question. So maybe trying to, let's say, to get the key learning that we review together, the three of us and the people connected. And again, thanks for your question. Probably the first one is that we have strong underlying evidence to support the use of the device in daily clinical practice. And we have, thanks to Stefan and the group, a sham control, randomized control trial in New England. So it's really that it means that it's innovation with strong evidence behind, which is not the case for all the innovation that we are using in daily practice. And following that, we also nicely review what could be the ideal candidate today. And we agreed that it's probably patient with refractory angina, no option for revascularization, and optimal medical treatment. And as far as we say we have evidence, we have patients for that. We've seen that the procedure, as you said, Stefan, it's a simple one. But as soon as we respect all the different steps, and Martin really just mentioned an important one is let's say, to remove the balloon, because we know the profile is not, could induce some embolization. So we really need to take time to be prepared to overcome the challenge. And again, we've seen that the rate of complication was very, very, very low in the different studies that we've seen. So I think it's really a great technique. It's useful for patients in whom we do not have any other clear option. And maybe in the coming years, it will be also used in other clinical setting. And as you said, Stefan, we have also on top on the studies ongoing for refractory angina, there is also studies ongoing from INOCA. We don't know the result yet, but we'll see that. And so that will be maybe a bright future for this technique. So again, thank you a lot for all the people who joined us today. Thank you, Martin. Thank you, Stefan. It has been a great pleasure to discuss that together today, and have a nice evening, morning, afternoon, according to where you are in the world. Thank you very much. Bye-bye.
Thank you. Bye-bye.
Thank you.